Good morning, good afternoon, going on to good afternoon, colleagues. Happy to have you all here. We are in the 9th session of the South Asia SBCC conversation, which ends today in another hour or so. And we have 4 very interesting presentations today, which are really themed around young and local stimuli. So without much ado, I will introduce myself. I'm Alka Malhotra. I work with the United Nations Children's Fund as a communication for development specialist. And I'm going to hand over to the first presenter today, which is Saswati Chatterjee. And she's going to be talking to us about breaching the digital divide, reaching adolescents where it matters in India. Over to you, Saswati.
Hi, Alka. Thank you very much for having us here. I am Saswati, and I'm the Assistant Manager of Digital Engagement in Breakthrough India. I'm very excited to be here talking about an issue which affected adolescents all over the world, and how we, regarding education, especially education of girls, and how we at Breakthrough sort of managed to breach that divide during a time of crisis, that is the pandemic. Thank you very much for having me.
Hi, my name is Saswati Chatterjee, and I am here representing Breakthrough India, an organization that believes in creating a world where violence against women should be unacceptable. We also work with adolescents, especially young girls, to help empower them and give them the space and agency to voice their concerns. So, first of all, let's talk about the issue at hand. What is the problem? In 2020, COVID struck. Lockdowns were imposed across the world and people retreated indoors to homes, societies, communities. The new public space was the internet, where people pooled together to contribute resources and talk to each other. But what about the actual public spaces? Workplaces closed, as did cinema halls, public parks, but most importantly, schools. The impact of that was drastic and immediate. In India especially, an estimated 248 million students suddenly no longer had access to not only education and schooling, but also their own peers. The world over, people shifted to an universe of Zoom classrooms and digital learning, but these remain a far-fetched dream for many in India. While internet penetration in India has been rising over the years, predicted to reach 900 million users by 2025, the fact remains that it isn't close to enough. The vast majority of India's population lives in rural areas, 65.07% as of 2020, and decent internet infrastructure on a consistent basis remains an urban phenomenon. All of this proved to be a stumbling block where digital schooling is concerned. With a lockdown that was called with barely 8 hours' notice, Indian school children were suddenly forced into a situation where they were relying on inconsistent internet and family-owned mobile phones to attend classes. Many of them had no access to their peers and were rapidly losing contact with school programs and initiatives. This was especially worrisome where girls are concerned. Many girls, once out of school, are in the danger of never returning, often forced to drop out and get married early. 10 million girls worldwide are now at the risk of dropping out of school. So what did we at Breakthrough do about all of this? Let's start at the beginning. At Breakthrough, we have a long-running program that we run in schools, Taron Ki Toli or Legion of Stars. Taron Ki Toli is a program through which we distribute gender-sensitive curriculum in the schools we are affiliated with. Not just that, we reach out to the children in these schools, the quote-unquote stars, to talk about gender-based discrimination, to empower them to raise their voices and talk about issues relevant to them, to create safe spaces for them to come, talk, and work together on creating a gender-just future. Breakthrough does this through many things: games, workshops, group activities, and we don't just work with students. Taroki Toli also involves teachers, parents, and community members to make it a successful program. And we are proud to say that it has been successful and effective so far, reaching over 30,000 adolescents in our intervention areas in 2019 to 2020 alone. With COVID and the lockdown, however, continuing Taroki Toli in its physical form almost seemed impossible. But our team at Breakthrough instantly swung into action. We began by adapting our Taroki Toli curriculum for online usage. By dividing it into sessions, we were able to make it more easily accessible for students. These sessions were organized via means most easily available to students, in this case, WhatsApp messages and calls. In many cases, where an adolescent didn't have access to a mobile phone, they gathered at a local coordinator's home whom they trusted and had interacted with to have the sessions. We also converted our curriculum into videos and comics, sent over WhatsApp for them to look at their leisure at home. Facilitators of our workshops were made available to talk to them as well. We are glad to announce that our adaptation of Taroki Toli was a success, and we were able to reach adolescents who were previously isolated in their homes and from their peers, and reconnect them with the spaces they had lost. It also highlighted for us a gap that we realized needed to be bridged. Going forward, we are continuing the digitization of our curriculum, not only to plug in the gap that we noticed during the lockdown, but also to reach out to a greater number of adolescents than ever before. While Taroki Toli was previously organized in schools physically and was very effective, we realized we could ensure a larger reach and deeper connection through a more customized and extensive digitization of our curriculum. As a part of that, we are currently in the process of working on an app which will streamline all the previously talked about processes. The app has seen feedback from all levels of our organization, from content to curriculum to programs, and its aim is to ensure that adolescents have the content and support they need as quickly as possible. We are aiming to have not only all our Taroki Toli curriculum on the app, but also ensure through it easy access to our trainers and facilitators who the adolescents can reach out to for questions. And with this, we come to the end of our presentation. We hope it was helpful, and as a concluding note, we would like to say that through programs like Taroki Toli, we hope to build a world which ensures that adolescents everywhere have access to both information as well as safe spaces with which they can empower themselves. This is how change truly begins. Thank you.
Thank you. Thank you, Saswati. Would you like to say just a couple of words before we... colleagues, if you could put your questions, clarifications, comments, reflections in the chat box here, because we don't have a question panel. We will pick them up at the end of all the four presenters, so we can give an opportunity to the presenters to revert on the questions and answer them as they come along. So if it's okay with everybody, then I will ask the next presenter to share their presentation, which is essentially combating misinformation through internet literacy for young people in India, and Yashi will be taking us through the experience. Keep your questions for the Breakthrough team as we move on. Over to you, Yashi.
Hello everyone, my name is Yashi Jain and I am a social impact professional currently working towards transforming the lives of adolescent girls and boys in India. Today, I'm going to present a campaign that we carried out at the 10 to 19 NISHTHA Adolescents Collaborative, a multi-stakeholder platform that seeks to transform the field of adolescent health and well-being in India through various interventions that include social and behavior change methodologies. Let's begin by identifying the problem and the gaps to be filled. In March 2020, as the world shut down and almost everything went online, it was not easy for a country like India to cope with this transition. A country where only 38% of households are digitally literate, the spread of misinformation was not surprising. According to a state study, India produced the largest amount of social media misinformation on COVID-19 among 138 countries over the last 2 years. At the same time, we also saw a rise in young people from semi-urban and rural India being forced to equip themselves to digital platforms to be able to access online education and information. As nascent and new users of digital platforms, this was a key demographic to reach and empower with the right tools for internet literacy, or they could also be lost to misinformation. We saw that by training them to use these platforms and engage with online information, we could also capacitate young people with the right skills to shift from being just consumer of information to becoming digital advocates during and beyond COVID-19. But why must we engage with young people specifically? Around the world, young people have really helped respond and recover from the COVID-19 crisis in various ways. They have been a resilient group who will potentially see the longest impact of the pandemic on their lives. At the same time, they have felt a sense of helplessness and loss of purpose. Thus, this is a key demographic to listen to, engage with, and learn from when rethinking public health systems, both in times of crisis and calm. Institutionalizing young people's participation has always been a key goal of the Ab Meri Bari campaign run by the 10 to 19 Dasra Adolescents Collaborative. Thus, at the start of the pandemic, we tapped into this key demographic to act as a catalyst of change with the objective to A. Equip them with much needed digital literacy skills, B. Train them to use those skills to combat misinformation and stigma in their communities and online, and C. To use those skills to also advocate for issues personally relevant to them during and post the pandemic. So how did we go about doing this? Along with the Ministry of Health and Family Welfare of India and UNICEF India, under the National Coalition of Risk Communication and Community Engagement, Dasra's Ab Meri Bari campaign led a youth-driven participatory communication campaign. With the support of our civil society partners, we onboarded 70 young people from across 7 states in India for a 3-month-long training campaign. We engaged with this group for over 7 sessions to learn how to do a number of things. 1. To examine and articulate varied forms of stigma and discrimination in the times of COVID-19. 2. To learn to use digital platforms such as Facebook, Instagram, YouTube to share and amplify their stories. 3. To apply key competencies such as systems thinking and learnability in leading small projects. And 4. To learn to apply storytelling techniques to influence a narrative shift. We deployed a gamification approach. After every training session, the youth cohorts were given tasks to complete that would push them to think of creative ways to use digital platforms to talk about important issues affecting them, such as stigma, child marriage, education, etc. To give you an example of the kind of tasks these young people undertook, they were to, say for example, pick one news channel of their choice, review the news that is being shown on COVID, note down instances where the content was preventing stigmatization and where it was discriminatory, carry out a family discussion on it, and create a post online sharing reflections and learnings of family members. To share another example, they were to run a social media campaign sharing every day for 10 days posts of hope and prevention of stigma and tag relevant organizations. Gamifying these tasks allowed for interaction, learning, and knowledge creation. A core principle throughout was to get young people to pick up critical thinking and advocacy skills, so they may apply the same to any issue which they are personally invested in. After 2 months of intervention, we asked our cohort of young people on the impact they felt due to their intervention. And we saw that 85% of young people felt more equipped to be on social media and running social media campaigns. 100% of them felt that they were able to sensitize community on stigma and discrimination. 100% also felt that they were able to make a difference in their community, while 97% felt more connected to the national and global community. Owing to this success, we decided to scale the intervention in 2 ways. One, we asked each of the 70 youth champions to onboard about 5 to 7 of their friends to be youth volunteers. And 2, we adapted UNICEF's youth training material and created a social media toolkit for youth digital advocates in English and Hindi to be disseminated across the country. Over 70 youth champions were trained to be leaders to be able to train 400 additional youth volunteers that they had onboarded. Our leaders trained these volunteers in similar skills of digital advocacy, storytelling, and systems thinking. They were equipped with similar tasks to build their skills and report stories from their communities, thereby creating a cadre of 500 plus youth digital advocates across the country with a mission to use digital ways to combat misinformation. The toolkit, on the other hand, was a guide to understand stigma, discrimination, misinformation, and the role an advocate can play to combat these. It was a step-to-step guide to also understand the use of different platforms and how to leverage them. It also provided readers tasks that they could complete to put their skills to test. This toolkit has been published and circulated by the Ministry of Health and Family Welfare in India, and other various youth-facing organizations have benefited from the same. The entire campaign proved to be a valuable effort in risk communication and community engagement for the country, and young people are still reaping the benefits of digital literacy skills built and their understanding of COVID-19. There were quite a few learnings that emerged from the campaign. To share a few, we believe that the design and structure of the campaign seamlessly worked to ensure the pre-intended outcome was achieved. Both phases of the campaign ensured that first youth champions were trained well, and then youth leaders were able to practice and apply the key competencies of systems thinking, empathy, taking people along by leading action projects. The importance of partnerships and participation also really emerged. We facilitated partnerships between young people, government, and NGOs through this intervention, and it has been a great learning to see the power of collaboration come to life. 500 plus posts were created by these young people that have also been amplified by various organizations and within their local communities, thus spreading accurate information and stories from the ground which might otherwise have been wrongly reported. A few of our learnings have been that it is not easy to reach the remotest of places. This intervention was possible with people who at least had one smartphone in their household. There are still a large number of people who do not have this access, and we must think about innovative ways. Realizing the tremendous potential that young people have, this year we took the campaign a step further and launched a program to train a group of young people in mobile journalism skills, which taught them the tangible, intensive skills to be a responsible journalist. Young people continue to leverage these skills even today, and you can see what they have to say on the right of your screen. Finally, I would like to end by saying that it has been a great journey, but we have a long, long road ahead of us. And we hope to continue to mainstream youth voices and work towards institutionalizing participatory approaches to involve them in the transformation journey of public health systems. And we hope you will come along with us on this journey. I sincerely hope this was an insightful presentation, and I'm here part of the audience to help answer any questions that you may have. Thank you.
Thank you so much, Yashi. Very insightful indeed. And I think it really is about creating champions with champions. So the first 70 champions onto another 400 champions, and very interesting tasks that you gave to the young people to practice the skills that they were learning throughout this exercise. Colleagues, please put in your questions, your clarifications, reflections on scaling up in the chat. We're happy to be answering them as we move along. And now I'm going to invite the third presentation for this session today, which is on community support team. strategy proves effective in combating COVID-19 in Bangladesh. So we are going from India, breakthrough, Dasra, onto Bangladesh. We have Zubair Shams and Sukumar Sarkar here. I think with us, I can see Zubair, and over to the presentation. Thank you.
Hello, welcome to the presentation on Community Support Team, a strategy for combating COVID-19 pandemic in Bangladesh. This is Dr. Sukumar Sarker from Save the Children Bangladesh. We'll be talking about this strategy today. Bangladesh experienced its first case in March 2020, and then also the death in March 2020. And since then, the country experienced 3 waves of COVID-19 pandemic. It was assumed that hidden cases in the community and unreported cases in the community are spreading the disease, as the transmission was kind of a community transmission in the country. Bangladesh has a strong community health system with a community clinic serving the lowest tier of the health system, serving about 6,000 to 7,000 population. The government and the development partners, consultant, and they felt the reality, they felt the need to use this community health system to respond to COVID-19 pandemic in the community. From that idea, Save the Children developed a response and a strategy which is termed as Community Support Team Strategy. A community support team is a team composed of community health workers working in a public health system and the community members, including the local government members. It is a community clinic-centric approach. As I told earlier, a community clinic is the lowest post of the community health system, serving a population of 6,000 to 7,000 population. The project launched the model, the CST model, in 6 districts initially by March 2021. The CST model adopted interventions to increase case reporting and detection, appropriate case management at home, including referral, and to increase the community response to prevent and control COVID-19. The community response includes community awareness and actions that are required to support the control activity. The project took some strategies to implement CST. For example, there are awareness raising activities with the help of community miking, distribution of posters, leaflets and stickers with call center number, and also engagement of the local community and allied group. To improve case detection, project trained the community health workers on how to screen and classify suspected cases, facilitate testing and reporting of suspects by the community and CSWs. In some areas, the project also supported transportation of samples from a sub-district level to district laboratories. To improve the case management, the project trained the community health workers on case assessment, as I told earlier, and then the project also trained them on follow-up of post-COVID cases, those who are returning from the hospitals. This is the graphic of the total model, how the model works. I'll not talk in detail about that one, but let me tell the little features, the important features that are kind of working in this model. This slide is an overall implementation modalities, algorithms, and how the CST is working. The core of the intervention, which is there in the slide, you will notice that is a call center at the sub-district level health facility, which receives information on suspected cases or COVID-like illnesses from the community, and then encourages testing for those affected persons, provides telemedicine service to the callers, and triggers home visit by CSWs, the community health workers, to assess the caller and make follow-up visits, including the post-COVID follow-up. We also distributed many protective items, BCC materials, like leaflet and stickers to the community health workers, and some training materials to improve the understanding of the CSWs on the CST model. You see the list of the items here. there are pulse oximeter and infrared thermometer given to CSWs to help them assess cases at the household level. And then there are also BCC materials like leaflets, stickers, posters to distribute in the community to raise awareness. The workers are also given a set of training materials as you see the list in the slide. Here are some results we have achieved so far from April 2021 to September 2021. More than 1,500 CSTs are functional now in these 6 districts of 9.7 million population. And then these household visits in this area, the CSTs and the CSWs working there, they identified around 75,000 or over 75,000 suspected cases through household visits in 6 months. At the same time, they followed up more than 6,000 post-COVID cases in this working area. They also sent or referred several severe cases that they assessed during their household visits from these 75,000 of the suspected cases. So this intervention, as we see, that creates a large number of visits, identification of cases, referral of severe cases, post-COVID follow-up. So in terms of impact, we didn't measure the impact, but the number that is creating is kind of a good achievement for the health system, and it is creating an example in the community health system to maintain a system that can be responsive not only to COVID but also to many other illnesses. As we see that Save the Children in Bangladesh is expanding the intervention in more districts. From 6, it will now expand to 20 districts, and by February or March 2022, we'll be working in 20 districts. We have seen that the local level health managers are able to lead this intervention. This is one good strength of this intervention, that they have owned, they have bought in the leadership of the intervention, and they implementing it. The community clinic providers and community support groups, which are also the community members of that community, are also engaged in this intervention to support the CSWs, refer cases, encourage them for testing, or providing any other support that they require. The call centers triggered the CSWs to conduct targeted household visits, and then these visits they conducted within their multi-purpose function. So it is kind of a sustainable within their routine work. The local level BCC activities also created community awareness, and nowadays we notice that the initial stigma around COVID-19 is almost gone. So therefore, this intervention has a potential to sustain. As I said in the beginning, that the CST model, so therefore, has the potential to sustain as a community health system model to respond to any emerging infectious disease or any future epidemic in the country. And that is where we see the potential to expand. And then not only to expand for this disease, we are now working with the health system so that they can actually build in the data management of this system within the data management system, so that this system, the platform, can also be used for any future epidemic. I'll stop here and then wait for any questions. If you have, we'll be here to respond to your question. Thank you very much.
Great. Once again, I'm reminding colleagues, please put your questions in the chat. We will pick up all the questions together. Zubair is here with us, and the presenters will be answering questions at the end of the presentations. We have some time, which is great. So the last presenter for today is Priyanka and Krithika from, and they would like to introduce themselves. The presentation is on an IVRS-based social listening platform for risk communication and community engagement that enhances equity and self-reliance. So over to you both, and then we'll have the presentation.
Thank you. Thank you so much. Hi, everyone. I'm Krithika Murali, and I lead the communication and documentation portfolio for the NISHTHA project in Jipaigo. And I also have my colleague with me, Priyanka. You would like to introduce yourself?
Hi, good morning, everyone. I'm Priyanka Shah, and I work as a knowledge management officer in the NISHTHA team at Jipaigo.
Asim, you could start the presentation. Thank you. Good morning, everyone. Today I will be taking you through NISHTHA Swasthya intervention, which is a social listening platform developed for risk communication and community engagement. The COVID-19 pandemic brought in unprecedented challenges to communities and especially the marginalized people across the country. These people were most affected not only due to the widespread lockdowns, but they were also residing in media dark areas wherein they were unable to access timely information. Further, an abundance of misinformation also added to this chaos. There was an urgent need to develop a risk communication platform to ensure that these vulnerable and marginalized communities have access to accurate, timely, and reliable information. Further, it is also important to note that in these areas, there was low smartphone and internet penetration, due to which there was a need to develop a system wherein they can easily access information without having to rely on internet or smartphones. So this brings us to the NISHTHA Swasthya platform. So what exactly is NISHTHA Swasthya? So USAID's flagship health system strengthening project NISHTHA, in partnership with Vaani, set up an alternate communication platform called NISHTHA Swasthya to ensure that these vulnerable communities residing in media dark areas have access to accurate and timely information. So what exactly is this platform? This platform ensures that there is community awareness through risk communication messaging through an IVR-based system as well as a mobile-based application. Now it is important to note that this platform has a two-way communication platform wherein the users not only listen to the important key messages that are being sent out, but they also have the option to record their views, their opinions, their grievances, which are then addressed through a dedicated response system. Now, when we look at the target audience, this particular intervention was targeted for vulnerable communities, including the migrant workers, elderly, persons with disability, and other people living in remote and media dark areas. And the geographies of intervention are in 4 districts in Madhya Pradesh, that is Barwani, Guna, Khandwa, and Rajkot, and Ranchi in Jharkhand. Currently, we are also expanding this intervention to the state of Chhattisgarh. How does the NISHTHA Swasthya platform work? So any user who wants to access this platform will be given a toll-free number. So there are 5 different toll-free numbers for each of the districts, wherein once a user calls that particular number, they receive an immediate missed call and they receive a call back within a minute. Once they receive the call back, the users have the option to listen to the array of content that is there on the platform. So here again I would say this content is divided into 3 formats. There's a studio generated content, which is basically the content that we develop through either through an audio drama format or through a story format, and it is information that we want to pass on to the communities. So studio generated content is that. Then secondly, users also have an option to record their comments, their acknowledgements, or any of their views. So that forms a user generated content, which is also screened at one end and then put on the platform. And then thirdly, users also record their grievances on the platform. So what works in the back end? One is that it is important that we regularly update the content based on the changing needs of the pandemic. Second most important part of this platform is that there are a set of community volunteers who are identified at the community level, who then go about to mobilize the community, inform them about the IVRS, help them to record their grievances, and also these are the faces or these are the point persons who ensure that whatever grievances are recorded by the community, they ensure that these grievances are resolved at the community. And then there is also through these community volunteers is ongoing feedback which is collected from the community to understand what are their communication needs, what is the information gap that they want to know more about. So this helps us further in regular the content updation. And lastly, like I said, there is resolving grievances and recording the user experiences. So communities have the option to record their grievances, and then this is taken up by our community volunteers who connect with the government officials and try to ensure that these grievances are resolved, and then these experiences are further recorded back on the platform. This which creates a system of trust that this is a platform where they can go to for sharing their opinions, listening to information that they need, and also recording their grievances. So like I mentioned before, one of the most important components of this whole platform is community mobilization, and this was done through community volunteers. So these community volunteers are local people identified from these intervention districts who are then trained on the functionality of IVRS. Then these community volunteers hold regular meetings with the community wherein they explain about the IVRS, and this platform is also used additionally to get the understanding of what are the communication needs of the community, what is it that they exactly want to know, and then further this helps us in weaving the content accordingly. Then over time these community volunteers are organized into clubs and more modalities are added as listenership increases. These community volunteers also act as reporters on the ground, and they also go ahead and interview other key influencers about any key information that we want to pass on. For example, the CMO, the Panchayati Raj Sarpanch, to pass on some important messages on COVID-19 and urge the community to follow COVID appropriate behaviors as well. Coming to the results of the platform, this initiative was started in July 2020, and the results that you see on the screen are as of September 2021. So we've had about more than 97,000 callers logging into the platform with more than 5,60,000 calls, and more than 15,18,000 minutes of content have been heard till date. So as you can see, the content themes were different based on the changing needs of pandemic, starting with COVID-19 prevention, COVID appropriate behaviors, mental health, COVID-19 vaccination, and we were also able to resolve about 2,374 grievances on various issues, including social protection schemes, information on COVID-19, essential health services, and other issues such as water, electricity, etc. So what you see on this slide is a beneficiary from the NISHTHA Swasthya platform. A young farmer from Guna MP had to take his mother to the hospital as she was having painful mouth ulcers. On reaching the hospital, he realized that he had to incur a lot of expenses which he was not able to afford. At this point of time, he remembered the NISHTHA Swasthya platform, called the number and recorded his grievance. Within a matter of days, he received a call back, and he was informed that they were eligible for a PMJY card, and the team helped him in getting this card, so that he was then able to ensure that his mother's treatment was free of cost. Now this helped in creating a trust in the community, and then he further went about and told his fellow community members about this platform, as this is a platform where the community could go to for any of their grievances, for listening to up-to-date information, and this went a long way in creating that trust within the community. So as you can see in this slide, we also did a baseline and endline for this intervention. A baseline was done in the month of July 2020 to basically understand, what is the current knowledge, what are the attitudes and practices related to COVID-19 among the community. So a set of about 10 questions were, put on the IVR platform, and wherein people recorded their responses. So this include basic information about COVID-19, also understanding was there any stigma, in their with relation to COVID-19, and also to understand, do they actually practice any of the COVID appropriate behaviors. So similarly, an endline was also carried out in the month of August, September. And as you can see, there's quite a significant increase in the baseline and endline in terms of the knowledge score, the attitude score, and the practices score. So what are learnings from the field? One important learning is that technology-based interventions require concerted on-ground community mobilization efforts. NISHTHA Swasthya was a platform which was accessible for smartphone users through a mobile application, and non-smartphone users through the IVRS intervention. However, it was also important that we give a face to the whole intervention through the community mobilization efforts, through the community volunteers, which helped in increasing the engagement of the community with the platform as well. Second most important learning is that there is a need to adopt a participatory approach. This helps in encouraging ownership and also builds the trust of the community. These community volunteers were from the community. They were trained and they approached their own community members. And also when people saw that the grievances were being resolved, so this further built the trust and also made people to start owning this platform as their own and record their views and opinions and grievances. The third most important learning that we had is platforms like NISHTHA Swasthya can effectively be used as a social listening tool. So this is a platform where community would come, record their opinions, their views and their grievances. So this helped us in also curating and a lot of the content that we needed to send out to the community. So basis the queries, basis the information that they actively asked for, the content was accordingly prepared and pushed out on the platform. Further, and another important aspect is that it helps in enhancing equity in terms of, especially for those communities in media dark areas or those vulnerable communities like persons with disability, elderly. These were people who were not really able to get out of their homes to, access information, and neither did they have, access to smartphones. So a simple phone helped in, ensuring that they were able to get this timely information sitting right at their homes. So this goes a long way in promoting the self-reliance of targeted communities as well. So this is the end of my presentation. These are a few glimpses from the field where you can see people accessing, the NISHTHA Swasthya platform. Also, there are some recordings that are happening. There are some interviews that are happening with the reporters on the field. And as you can see, there's also a person with disability who's accessed this platform. And we also do have considerable amount of women users as well. So thank you so much for your time and for your patience for listening to this. Thank you.
Thank you. Thank you so much for the presentation. I'm now going to open it up for questions. We have two presentations that used IVR and community engagement processes, which is from Bangladesh, the community support team, as well as the NISHTHA Swasthya. And we have two presentations that spoke about engaging with young people, combating misinformation, the Dasra example, as well as the breakthrough example of taking Taro Ki Toli into the online space and into a virtual platform of engaging with young people. So that's broadly the presentations that we have heard. There's one question for Zubair ji from Vaishali. The question is, how was hesitancy tackled in communities for a positive deviance in behavior? So this is the question for you, sir. While you answer this question, I'll just read up if there are more.
All right. Thank you. Thanks for the question. Actually, this was a very initial, what I said, stress that the program managers had to build the trust and the confidence of the community in favor of the intervention. And what we have seen in our intervention area, as well as in some other areas, what actually worked most is the engagement of the local community. If the local community is given the appropriate information, right information, and engage them in doing some response activity or participating in the health facilities activity, then they become gradually aware. So this intervention, we from the beginning engaged the community members, as it was a very much community clinic centric approach. So we engaged the community members and the local government members to work with the community and influence the other community members to learn about the disease and to respond to the disease. The other point is that the engagement of the religious leaders, as we know in our part in South Asia, the religious leaders still have a strong influence over the community behaviors. So engage the community leaders, religious leaders, and then also arrange for miking from the mosques. So loudspeaker announcements from the mosque, they read out the religious leaders, they read out the printed information, printed messages from those mosques regularly, and that created an influence. The last thing that I will say that is also very important, but in my observation, when in the first two waves, the disease was mostly concentrated in urban areas. Although it was in several cities, but it was mostly concentrated in urban areas. But when the country was actually hit by the Delta variant and the disease actually spread to almost every corner of the country. So the villagers, the rural people, they become affected from the disease, and the visibility of the sufferings caused from the disease due to the Delta variant, made them aware of the signs, symptoms of the disease. They become aware that this is a cough and cold type disease, but they also become aware that there are complications that could arise and that could kill people. So they became alert and they became participatory. I think that that phenomenon is also very important, and I believe this is in many parts of the world. Thank you.
So risk perception actually pushed people to start to participate a bit more actively. Correct. Thank you so much, Zubairji. I have another question. I think it's for Krithika. The question is, did community volunteers face challenges in reaching out to the community? Because in 2020, when most of these volunteers may not have been vaccinated, so how did they, especially in the beginning, when young people were not yet vaccinated, what were the kind of challenges that were?
Thank you. So yes, we did face this issue initially. Also, one is that they were not vaccinated, yes, and also secondly, I think the volunteers also faced a lot of stigma themselves because, they were going to the community, they were going to different places. So, people were a little hesitant to even, come to them. So at that point of time, what we did is we connected them to the community health officer. So NISHTHA also works very closely with the Ministry of Health and, strengthening the health and wellness centers platform across, all our intervention states. So we have a very strong connect with our community health officers as well. And health and wellness centers, as you all are aware, is the first point of care for the communities. And people trusted the community health officer. So we made this connect of the community volunteers with the community health officers to kind of, inform them about this platform. And also we did not do much of group meetings initially. There was more of a door-to-door visit. And when they were these small group meetings, what was done was we use this platform to kind of also distribute masks. And then, we would also have the community health officer also, talking about some COVID appropriate behaviors and all that. So that's how we countered those initial challenges. Thank you.
Thank you. Thank you. There's one more question. It's for Zubairji, which says, how do you think community ownership can be strengthened during the times of pandemics and disasters where there is risk associated?
Sorry, can you repeat the question?
I'll repeat the question. How do you think community ownership can be strengthened during the times of pandemics and such disasters where there is a risk associated? So how do we strengthen community ownership, community action?
Yeah, community ownership. Okay. First of all, this is Sukumar. This is not Zubair. Zubair is assisting me here, of course.
Sorry, my bad. Sorry,
no,
it's
okay.
just that I see Zubair over there, so I was wondering.
No, that's fine, because he is communicating on behalf of us. The community ownership, I think first and foremost is the information. Community needs to get the right information and what they should do. They should know that. And then sometimes people get panic because they don't have the right information. So they get panic about the, disease, they caught by the disease. So if possible, as we have seen throughout the world, the masks that we have using, so the mask distribution or promotion of mask use, and also talking about social distancing, builds the kind of confidence and trust of the community. So that is one aspect. And then second is their engagement from the beginning. If they're engaged in intervention from the beginning, for example, in Bangladesh intervention, we also conducted orientation for the community members along with the health workers. So a large number of community members also were trained. They were brought in, 25 to 30 people are brought in a session, and they were talked about, their questions were answered. So that way they were also engaged with the intervention. That is an important part. And then the third is their link with the local government. So if the local government members also keep a constant link with them, and they're tasked with some sort of responsibilities, that is an important component. And we have seen in other areas, in some areas, if the high-level policymakers, for example, if the administrator of that region, or if the parliament members who are responsible for that region, they become engaged. There are examples in Bangladesh that when a member of parliament got engaged, they were able to mobilize the community more. As leaders were engaged more, they were able to bring the community more participatory in the process. So, and then eventually community got ownership, and there we got a good result in terms of bringing down the incidence and prevalence as well.
Right, great. So there is a question for Dasara now, which reads, how skill building of adolescents on storytelling, critical thinking, and advocacy can be taken to scale and sustain. So what are your views on that, Yashi, on sustaining the intervention that you did, which from 40 to 70 to 400 and so on? Yeah.
Thank you, Shibash and Alka for that question. I think it's a great question, and a question that I think a lot of us who work with adolescents and are trying to center their voices and capacitate them have been grappling with, about how can we scale, how can we reach more and more young people, even the most remotest of places. So I think our effort through this intervention was, again, that now that we saw success in like a group of 70, how can we scale it to a 500? And a model that we came up with was, can they bring in their own friends and their volunteers to scale it up? So that's a great way. I think just peer-to-peer learning is a great way. And I think there's no one straight answer. And I think all of us are trying to find answers to this, but I think I can share some ways that have worked for us and ways that we are exploring currently for making it scalable and sustainable. So I think one way is definitely getting a group of young people and then asking them to do peer-to-peer learning, and just spreading that your network through that is one. I think second would be I think a collaboration of NGOs, and just like we created this toolkit for NGOs to take up and then take it to their their networks and their young people. I think that, and just us collaborating with government, with different stakeholders, is very key. I think all of us have that network, have that reach, but it's just about us coming together, using each other's best practices and things that we have learned. So I think that's also really key. I think the third thing is also, how can we involve young people more meaningfully? I think just involving them more meaningfully, maybe in our decision making, in our programming, bringing them on board as equal stakeholders can really help in just getting their buy-in and building their skills from ground up, and making sure that it's lasting and it's not just tokenistic, for lack of a better word. So I think it's important that we keep those lenses in mind, and I think once we do that, slowly and steadily scale will start to come in, and we will start to see that sustenance also coming in. Of course, there's no one solution to it, but that's one of the ways that we are trying to do, make this happen. I hope that answers your question, Shibash.
Thank you. I think, and I would just add one more to it, and that is engaging with platforms where young people are already coming together, such as NSS, NYKS. There are several such platforms that young people are already accessing. So there's a question now for NISHTHA again. It is on the IVR platform. So the question is the IVRS platform robust to integrate more content for youth? Is there elasticity in the system to move on to other issues?
Hi. So thank you for the question. So when the NISHTHA Swasthya platform was created, it was specifically done with the during COVID, and with the aim of sort of catering to vulnerable populations, and to let the sort of get COVID related messages and other essential healthcare services related messages across to these vulnerable groups. But beyond sort of COVID, we are exploring, involving youth, and that is also how we do plan on sort of keeping this platform sustainable. So yes, we are exploring these sort of other targeted groups, but this is all parked for the future.
Great. I don't see any more questions in the chat, but I have a question for the breakthrough team, and that's on you've taken Taro Kutoli into an online and into a virtual space, while we all know that life skills building is really about practice, about face-to-face, about young people talking about issues themselves, and also their own participation in this entire exercise. So just your experiences on and challenges as you took this to the space, and how did you compensate for that inability to really have people participate a lot more, the opportunity of participating? How was that kind of handled?
Alka, thank you so much for the question. I actually think that the whole experience was one about learning, because when the pandemic hit, it was a lot of things happening together. We abruptly lost contact with a large number of the adolescents that we worked with. A couple of things that we sort of used to connect the dots was that we knew about the availability of smartphones. However, as we talked about, smartphone penetration is very low. So as I discussed in the presentation, for families who didn't have smartphones, we had to find a local coordinator who was in the area, and the children or the adolescents were already comfortable going over to their house, especially considering the pandemic. So it was, initially it was very much an adaptation, because we had to find a local area where the adolescents could gather. We had to find smartphones through which either the coordinator had to have them or the families had to have them. In many cases, we realized, especially for women and girls, the family may have one smartphone and it was not accessible to the girl, which was how it usually went. So it became a process of coordination, and we realized that one of the platforms that they most actively used was WhatsApp. Because a lot of the schools in the area also used WhatsApp to coordinate with family members, etc. So we started sending lesson plans and videos over WhatsApp, and there would be very small proto lessons and proto sessions which would happen at the coordinator's house. But obviously this had a lot of gaps at that moment, since it was an adaptation. But we also realized that previously, the people that we couldn't reach through schools, we were now reaching a lot more adolescents, simply because they were at home and we had, everybody had WhatsApp, or their families had WhatsApp, or they knew somebody who had WhatsApp. So we are trying to plug in these gaps through the app, where the interaction part can be satisfied. So we're trying to have like a greater access to the facilitators via the app. So, at any point, if the children or the adolescents ever feel that they have questions about any kind of topic, health, hygiene, sanitation, sexuality, not sexuality so much as sexual education, etc., SRHR, they can reach out to the facilitators who they trust, which was the important point, through the app. The app also had the various interactive activities that we're currently in the process of testing, like, questions about body, questions about, empowerment, female agency, etc. on the app. So it's still something that we're in the process of working on, but we've seen really good feedback via the adaptation. So, fingers crossed for the app. Thank you so much.
Thank you. Great. So I'm going to sum it up now. We have only 3 minutes to go, 2 minutes before we all join back into the final plenary, and let's, as a group, take some actions forward after the 3 minutes. But what I'm going to say is today's session really has shown us with examples how we've merged the offline and the online, the physical and the virtual. And this is a starting point. So taking us from here into this journey of what we call hybrid ways of engaging with people face-to-face as well as virtually has been an opportunity of the pandemic. The second is around the fact that beginning with COVID, we went into several other spaces, from misinformation to hygiene education, SRHR, as you just mentioned, health and nutrition, and life skills. So I think that's again taking it as an opportunity of continuing to engage with the people that we began engaging with using these mechanisms. And the third very important takeaway for me, and I'm sure for all of us in this room, is really around how the interventions have built accountability, ensured and built self-resilience and trust among communities with each other and with the systems. So I think that's really been one learning, that despite the fact that people were not really connected and we used various virtual means of staying connected, accountability, resilience and trust have main takeaways from these kind of interventions. So this is just the starting. It's the connecting the dots and a way forward into the future. See you in about 3-4 minutes in the other plenary room. Please do not leave. Use the link in the chat and join us back in the plenary where we can all connect again and take some decisions on behalf of all of us. Thank you so much, presenters. Thank you for the audience and the wonderful questions that have happened. Thank you.
Thank you.
See you.
Thank you.
Thank you.
Bye.